Hello, everybody. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I would like to welcome you to today's webinar by Health EC called Managing the Unmanageable, Providers, Partners, and Patients. A few items of note before we begin. All attendees have joined the webinar today in listen-only mode, so you don't have to worry about muting your mic. That'll be done for you. I would also like to inform you that the webinar is being recorded, so you'll have the opportunity to rewatch the session or share it with colleagues. And a link to the recording will be emailed to you after the presentation today. Finally, during the webinar, you'll be able to submit questions to our presenters using your attendee control panel. And we will answer as many of those as we can get to in the Q&A session at the end. The questions that do come in that we're not able to get to, we'll follow up and answer them via email afterwards. So don't worry about that as well. Our presenters today are Dr. Sanjay Seth, who's the Executive Vice President, Health EC, and Cliff Frank, the Interim Executive Director of Shore Quality Partners. Welcome, gentlemen.
Thank you, Garrett.
Thanks. Thank you all for joining, and hopefully we can communicate or give you a little bit of insight into how we've combined the data with operations to help with these difficult situations. And I don't want anybody to take what we're going to talk about lightly, because these are very sensitive issues that cannot have a cookie cutter approach. It must be done patient by patient, provider by provider, or partner by partner, and you need to use your data selectively as well as judiciously to decide if it's going to reach a boiling point that the overall strategy of the ACO and the performance is not affected. So I'm going to start with the first slide to talk about managing the unmanageable patients.
Can we set this up? Can we set this up with a little context for people?
Sure. Why don't we do that?
The problem with ACOs is that the providers don't control anything. We don't control medical necessity determinations. We don't control authorizations for services, referral authorizations, or anything. We just have this bolus of patients that we have to somehow manage. And what is unmanageable and proven very difficult is this whole notion of having the patients kind of follow the direction that they're given or coaching that they're given when they may be pulled off or run off to the mega group that's down the street, or to some alternate practitioner or somebody they used to see for a similar condition, but now maybe that provider's not in the ACO. So all of this is, if this was just a straight HMO, we could kind of command and control things a little better. We have no such levers. So given that, how do we manage the unmanageable?
Right. Thanks, Jeff. And I think that if we talk about patients, as a physician, I took the approach of prevention and then cure. And so we want you to realize that make sure that the ACO or the participants within the ACO are not the cause for making a patient unmanageable. And I've tried to highlight some of these issues in the next slide, where what causes patients to become unmanageable. And in the prevention category, if the access to providers, whether it's your PCP or a specialist, is an issue, if the patient is unsatisfied with their encounters within the office, and there are a whole host of issues that cause unsatisfaction or dissatisfaction, and that could be long waiting times in the waiting room, and then waiting in the examination room, and then the the exit or the discharge process from the practice is also a long, drawn-out process. Certainly, that causes dissatisfaction.
Or lack of good communication with the provider.
And so, social determinants. Patient is unable to come. They have childcare issues. They don't understand their benefits. So when a claim is processed and then you ask the patient for a balance, they want to know what the hell that's about. So those are some of the issues. And then the individual frustration of the patients who have chronic illnesses that are required to see multiple providers, that have to come back into the office multiple times. They have to come back, they come for one visit for blood work and then another visit for interpretation and then another one for treatment. These are all causes of that we are avoidable or preventable. And the symptoms of all this is patients don't keep appointments. They go to the emergency room themselves. They don't want to go through the process of getting an appointment 3 weeks later, or they make self-referrals.
But wouldn't that also be true of a patient highly utilizing urgent care or telehealth?
Correct. So these are the patients, if telehealth was so convenient, yes. So these are symptoms of what we think are problems that create this situation for patients. And the consequences are that you have low satisfaction scores, and with the Medicare shared savings programs, the CAPS survey is really important. It factors into your ability to continue to participate in that program. Low satisfaction also means they don't come to the office, which means low compliance. If they're low compliance, you get low quality scores because you can't do all the screenings that they have to go through and all the quality measures, and higher cost eventually. Or they pick a different provider. Now you're losing what could be your low-cost patients. And that has changed your payer mix. It has changed your risk score. It has changed your averaging cost. And so these are the consequences of having issues with patients becoming unmanageable. Now, we do have a process, and in the days of providers calling patients with a big medical chart, a fat binder or a fat medical record syndrome, where the medical record was bursting at its seams. All of them have a reason. If you don't go back to do that root cause analysis for that patient to have such a big folder, either their chronic illness or their care is not adequate in their opinion, it's going to cause a problem. So the first part is managing the unmanageable patient, is to make sure you're not the cause of being unmanageable. The question is, what do we do with these patients? And we thought of dividing this into what can we do through better provider engagement and what we can do with better payer negotiations or contract negotiations. And with the provider engagement, one of the things that we have to talk about is practice transformation. And I left the words after two blog because there's so many aspects of care within a practice, or so many processes within a practice that need to be fixed, that are the cause of the problem for the patient's unsatisfaction. Improved access and engaged encounters, and this is what Cliff was referring to, is if the provider is only spending a couple of seconds in the room where the nurse or the staff are doing most of the work, and not all patients are satisfied with that. Maybe an executive who has only 10 minutes is okay, but the regular patient, Medicare especially, one of the reasons we all know that Medicare patients come to providers' offices to socialize as well, because that's their only contact with the outside world often. So you have to be aware of that. Certainly addressing social determinant issues, whether it's transportation, benefits, or simply understanding and coping with the illness that they have, could become issues. Chronic care management is really a double benefit for every practice. One, it is a great source of revenue. And two, it creates an opportunity to have multiple touch points with the patient. And having multiple touch points with the patient may give you insight into the patient's real problems and what needs to be addressed first. and which patients need to be brought into the office as an encouragement. So chronic care management is something that will improve provider engagement with the patient and the provider's ability to understand issues that ultimately affect the ACO. Similarly, managing transitions of care and making sure that a wellness visit is scheduled with every patient gives you multiple opportunities to engage with the patient and avoid unnecessary utilization of expensive resources and or helping you prioritize which patients need to come into the office. Cliff?
One of the values of that wellness visit is to identify nascent problems that are likely to emerge over the next year or two and get ahead of it. By that I mean not so much on the clinical side, but if there is, for example, a dominant orthopedic group in the county, or there's a dominant cardiology group in the county that's not part of the ACO, and the patient has a little complaint that eventually would take them there, addressing it early and even making an alternate referral at the early part of the process allows a new relationship with a specialist to get born before the patient suddenly decides that they woke up with a sore back and they're running off to a super specialist completely bypassing the primary care.
And I think that what Cliff and I are both trying to stress is better provider engagement. To have better patient engagement is really the way to manage the unmanageable. I mean, it really should be a absolute point of no return if a patient becomes belligerent or becomes uncooperative. Again, even if that were to happen, remember early onset of dementia and Alzheimer's, the first symptom that we typically miss is belligerence, is antisocial behavior. So I know some of our spouses start arguing with us. Maybe it is a form of early dementia, but that is one of the earliest signs of dementia and Alzheimer's, that the patient is confused and they become belligerent. And so recognizing that is really important before you truly say this is an uncooperative patient. Through our payer negotiations, through the ability to have a discussion, not for Medicare specifically, but for the MA plans and Medicaid and commercial ACOs, a conversation with the payer could help. The payers will take over responsibility of finding an alternate site of service or a provider for a particular patient that doesn't have access to the right group of consultants. But in the Medicaid world, auto-assignment is an issue because the providers and the ACO don't even know that these patients have been assigned to the ACO for mere fact of being a zip code analysis. And so keeping a track of that is important. Unreachable, uncooperative patients can be handed over to the ACO, to the payer to help in terms of getting the patient engaged.
Or getting them moved.
Well, getting them moved. HEDIS measures require continuous enrollment. If you're looking at performance of your scores and you don't have continuous enrollment, this is a conversation that you could have with the payer and say that I'm going to enforce my continuous enrollment provisions. Focused management of patients with unique and exclusive problems. Cliff has a really good live example of dealing with the Medicaid population ACO that he had, where hepatitis C and treatment of hepatitis C was an issue. Cliff, you want to expand on that?
Well, when Harboni came out, I knew we were going to get whacked. And I tried to get those cases included in the stop loss, or lower the stop loss that would then cover me. They refused the Medicaid plan.
Right.
So what we did instead was to try and route those patients through a referral relationship with a group of physicians that had access to 340B drugs. So that the unit cost of those drugs was materially less, and so it was not so painful for us. These patients were, I mean, that group that had access to 340B was still in the market, but we would make a kind of a standing referral to them, and they would then care for the patient while they were under treatment for Hep C, and then send them back. So that kind of arrangement was a little creative, but it certainly helped the patients get access to the drugs, and we were able to kind of
mitigate some of the expenses.
Exactly.
And I think that, and we can say now that has become a part of the next year's negotiation process. That are we going to change the stop loss? Are we going to change exclusion?
Well, unfortunately, some other drugs have come on the line that are not quite so expensive. So, that's the problem. Is if you fix something, then something else breaks. So this is the sort of thing which you never can let up on, because it's always dynamic.
And we're seeing that with diabetes too. The new medication for diabetes, which is at 20 times the cost of metformin and the other oral hypoglycemic agents that we were using, has certainly changed cost structure. And so these things are dynamic. It's not a one-time.
But that begs another question, which is what's in your deal and what's not in your deal. If drugs are in your ACO deal, then that takes you down a more comprehensive view of how the options available to managing these otherwise unmanageable patients. If drugs are not part of the deal and it's simply your base medical and facility claims, that really it opens some doors, closes other doors, but it just may take you down a somewhat different path. What's best for patients has to kind of trump everything, but inside that there can be options that are available that may have a differential impact depending on how your contracts are structured.
And in the Medicare ACO programs where we don't have Part D data, it's not included, Part B medications are also extremely expensive. We're talking about infusion programs for oncology and infectious disease. So you have to be aware of the cost and find your best alternatives. And it is going to come through provider education, which I think the next slide talks about, which Cliff's going to focus on, is managing the unmanageable providers, which is, a political nightmare in some forms. But Cliff, what do you think?
It depends who owns you. If you are a physician-only network that has the ACO infrastructure and contract, how those entities deal with each other is materially different than when you have a hospital-sponsored ACO. And we've seen the results, differential results in the data. Fundamentally, it's my belief that you give doctors good data, they will generally rise to the challenge and challenge each other. Nobody likes to be either at the top or the bottom of the list, and they certainly don't like being called out by their colleagues. Our ACO early on went with the whole open, transparent data. No masking of the data. We just ripped off the Band-Aid, to use one of the doctor's phrases, one day, and just said, okay, we're done hiding behind A, B, C, D, E, and just put the names on there and let the chips fall. And that good data gets generally a good response. Bad data gets a bad response. And by that I mean...
no data.
Well, no data is a different response. But bad data is kind of worse than no data. Because bad data gives everybody an excuse to kind of not deal with the reality because the data is not right. Where that usually happens is when the reports are delivered at the tax ID level, because that's all Medicare has. That's all the insurance companies provide. Sometimes they'll provide rendering provider. A rendering provider is missing in half the claims, so it really doesn't give you a good picture. You've got to have a data system which gets you to the NPI level. And then when you have that, you can hand a doctor a list of patients that are high risk that they haven't seen and say, will you please love these patients better? And they'll respond, because they'll know the names that are on that list, and they'll know that they're patients. When you hand that same list, that's your best guess as to who those patients are, and the doctor looks down that list and says 4 or 5 of those patients aren't his or her patients. Then the whole list is junk, and that's the last time you'll interrupt his or her day with a bad data report. So having good data gets providers started, particularly at the primary care level. At the specialty level, good data is really hard to accumulate because the N's are too small. You cannot have anything that's statistically significant, even if you have 15 or 20,000 lives. And when you get down to the specialty level, you're talking 20 or 30 cases for any given practitioner across the full range of diseases that they treat. Really hard. So you're really left to more qualitative measures and measures of responsiveness. Is the doctor getting back to the primary care doc? Is the doctor sending the patient on to another specialist without routing that patient through the PCP? Secondary referrals are kind of not very helpful, and if you have providers who are routinely doing that, they become unmanageable providers and may need to exit the network because they're doing a lot of damage. One thing you can give the specialty providers is where their patients are ending up for facility care. Because if there's in a market where there's a big difference, or this network is sponsored by a particular facility, and that's where they want the expectation is that's where most of the work will go, then and it's not, there's a lot of leakage. That's not just the primary care doc's responsibility. The specialists have a lot to say with that because they take the patient to a particular facility. If the specialist isn't one in the network and they got there either by themselves, but the patients got there by themselves or were referred by the ACO primaries, that's a different problem. Also needs to be addressed. But if for specialists that are in the network, they may split among facilities, or their group may be divided among facilities, and these two doctors cover the one facility, but the patient somehow through scheduling ended up with one of those other doctors in the group. Those kinds of problems can be raised and pointed out through downstream data analysis and then reflected back to the specialist. The problem with all of this is the specialists really aren't going to care until the primary care physicians call and say, we need you to pay attention to this. If the primaries aren't willing to kind of make those kind of calls, then it's really an uphill climb. But provider-to-provider interaction is really necessary to move the needle on provider manageability. As much as I, as a layperson, would like to come up and slap down a report and say, look, here, these are problems, that doesn't work. What works is to have a colleague-to-colleague discussion around that same data. And frankly, the layperson is the least important person in the room.
Again, like I said in the beginning, these are not simple, straightforward issues all the time. They need to be a response or a strategic plan needs to be developed with all this information in mind, and don't try to make it a cookie cutter approach. And that's one of the things I wanted to stress on.
One of the things we have done that was, for the primaries, a lot of fun, was we had them rate every specialist on a 1 to 5 scale on 4 questions. Did the specialist see my patient in a timely fashion? Did they do a good job as far as caring for that patient? Did they send them back? And was the patient satisfied? And the primaries rated 200 doctors on those 200 specialists on those characteristics, and it affected the specialist bonus pool, because if they were lower scoring, they got less. Now the problem with that is it's much more symbolic value than real, because the specialist bonus pool in any ACO, if there is one, is fairly small, $500 to $2,500. The primaries may be picking up 10 to 50 grand, but when you have so many more specialists, it's going to dilute the pool. But the specialists knew that they were being scored, and those who kind of fell outside, the 25th to 75th percentile, got the data and were quite uncomfortable.
I think in those situations, it's not the actual dollar figure at the specialist level. It is the referrals, because that's where their sustenance is. It's not in the bonus provision. Relatively speaking, in an ACO, the dollar figure for some of these specialists is irrelevant. When you talk to cardiology and orthopedics, unless you're talking in the hundreds of thousands of dollars as bonuses, doesn't impact them. So you have to understand that unless you're in one of these exceptional ACOs where you're distributing tens of millions of dollars, where you could make a difference even to the specialist, it is one of those things that we can't really enforce as much.
Well, and one of the things we have done in our ACO for Medicare is that we formed a new one, and we only invited PCPs to be part of it, so as to make the shared savings pool much bigger, probably 40% bigger, and impactful. So,
and that was a direct result of the fact that giving them small bonuses didn't really move the needle.
No.
But having them rated,
that moved the needle.
Which changed how many referrals they would get, certainly made a big difference. And I think that it sort of lends us into the next slide, or leads us into the next slide, where we're talking about partners. And Cliff has already brought up the issue about super specialty groups, or super groups, as some people like to refer them to, which eliminates the freestanding specialist in the community, and you're forced to reckon with a big guy, and so that's a whole different approach to managing it's not an unmanageable partner. It's sort of you're between a rock and a hard place in terms of who you can use within your service.
Well, and how you live with them becomes really kind of delicate. A lot of these super specialty groups have developed central scheduling, which is really helpful, because you can then have a conversation with their leadership about navigators, tagging patients with primaries, and making sure that patients come back to that particular primary, and if there has to be a procedure, it gets done at that primary care's designated preferred facilities. All that can work until such time as the patient starts self-referring.
Right.
And then, after the third visit, it finally becomes evident that the patient's primary care doc is not necessarily who was on the registration slip. And then somebody has to kind of figure that out. And generally, that doesn't happen.
And the creation of these super groups is in infancy. So they have not reached the level of sophistication as if they were one. In name, they're one, but in operations and practicality, their individual practices all over the place. And so the example that Cliff used may not be available or visible or even evident in most conversations today. Maybe over time we will see a better organized super specialty group, but one has to be careful about how we deal with super groups. The alternative can't be that let's go and hire our own. That changes how the approach is, and that is coming back to the field of dreams. If you build it, they will come. That's not anymore. So let's talk about some of the partners that we talk about and that we typically see within our ACO's operations and home healthcare and DME providers, urgent care centers, and skilled nursing facilities. I've seen a lot of experience or a lot of variations in how those are handled. With the MCOs, with the managed care entity, value-based contracts, skilled nursing facility direct admissions are not an issue. But if you're in a Medicare shared savings program, you need to opt into the 3-day waiver. And once you do that, you have the ability of creating a narrow network. And that gives you the ability to have a conversation with the skilled nursing facilities and saying, listen, if we are going to use you predominantly, this is what we'd like you to do. Have beds available to us whenever we need it. And make sure readmission rates back and forth between the hospital and you are not there, or even dedicate a navigator or a case manager or a nurse or an FTE to our providers' practices, staying in touch with our practices, reminding them that they have this option. While the counter to that is to talk to the providers in the ACO as well and say, listen, this is our preferred partnership. This is what we get from them. Here is the advantage of using our partners. Both of those conversations need to occur.
So where that whole thing breaks down, unfortunately, is that when the patient is presenting at the ER or at the hospital, they've been there 2 days, and it's time for them to go, and we've got the 3-day waiver. But the 3-day waiver only applies to ACO patients. So how do we know, how does the hospital know that this is an ACO patient? They don't have toe tags when they come in. So we've had to actually create a database that the hospital can inquire that essentially has an ACO flag, because half the Medicare members in our market are in our ACO, and half of them are in no ACO.
Correct.
So we can end up by screwing this up. We can end up giving some people some real heartburn here.
Right. And we've seen that we have a hospital with Cerner on it, and they have let us send a flag for your patients that this is an ACO patient. So a different thought process needs to be applied here, not in terms of clinical care and management, but in how we manage discharges and how we manage notifications. And so I think there's a solution for some of these things, but it's easier said than done.
Well, that's why in all of these things we have to think about what's driving or what's attached to our universe as opposed to what's inside.
Talking about urgent care centers, they are a great alternative. And if you're in a neighborhood in the Northeast where ERs are packed and waiting times are long, they welcome the reduction in traffic into the emergency rooms. At the same time, if you're a hospital-based or hospital-sponsored ACO, emptying out the emergency room means fewer admissions automatically, and that's a difficult situation where the incentives are not aligned between the ACO and the hospital, as say. So again, remember, no cookie cutter approach. It has to be customized and be carefully thought about. But urgent care centers which have flourished or have not flourished, but have sprouted up everywhere, the sustainability model is in question. And they are not lasting, and they are often owned by providers. And so the difficulties of provider-owned urgent care centers are not sustainable. So here's an opportunity for an ACO to partner with such an entity and create a sustainability model. They could become the after-hours program for all the PCPs. So the PCPs have to stop taking calls at night necessarily. And technology has enabled the data sharing in terms of medical records, so the urgent care center can have access to the same information to manage the patients better, that's a bonus because one, it creates good transitions of care, better clinical management, sustainable, cheaper alternative to the emergency room. And if you're hospital sponsored and if you're running your emergency room overbedded and you're doing diversion for ambulances, this is a great opportunity to solve that problem as well. But if you have a hospital that has got an empty ER with wait times of 3 minutes or less, this is going to hurt. So you've got to be careful if you're sponsored or not. Remember, it's easier to make enemies than to make friends. And so don't create an environment where you're competing and creating a conflict when you know eventually you need them because you're moving towards a risk-based agreement that would include inpatient care, and you need those partners. So
the same goes with on the urgent care side. There are good urgent cares and there are bad urgent cares. And your doctors will know kind of from their own experience which ones are which. And if one of these that you're targeting is not so good, you're going to end up with some really unhappy physicians because the quality of care just won't be there. And no matter how much access they have to the medical records, if the doctors at the other end don't know what they're looking at, it doesn't matter what else happens.
So the example you used with how you ranked all the specialists, again, that's an approach to managing a poor, uncooperative, poor citizenship in terms of providers as well. With referrals, with specialists, with urgent care, skilled nursing facility, any of the partners, that's easier. If you have an unmanageable PCP that has a large number of your lives, that is uncooperative, that is not being a good citizenship because perhaps simply from not believing in the model, that is a very difficult decision to be made. And I know, Cliff, you've had one of those examples, and it took a couple of years to come to its end. But why don't you talk about that?
It's really interesting what you remind me. The first one took 2 years to kind of boil. The second one took three minutes. So the learning curve, I guess, was pretty steep. We had one of the things we do with our ACO is we provide doctors a list of their patients who are high risk that haven't been seen within 6 months. Now, if they're seeing an oncologist or they're seeing a cardiologist or pulmonologist, fine. We consider that they're being watched. But out of 1,500 high-risk patients, we had 300 of them who weren't being seen. And we had this one doctor who had 12 of them. And one of those patients had run up $198,000 worth of admissions, 3 admissions, and still hadn't been seen by the primary. And we say, well, why? And I said, well, the patient just didn't come in. Well, shouldn't somebody have dogged them a little bit more? And this doctor was not concerned at all. And then we got down to looking at the referral compliance with labs and other stuff. Finally, we just said, we can't do business. This is just, you're killing us. The second one was somebody beat up my care management staff, and was very disrespectful, and we're just not putting up with it.
Right.
So the FTC loves this because then you're actually, we're not just kind of a gang here. We're actually a clinically integrated network that's enforcing some behavioral standards. So, from that standpoint, it was good. But yeah, between the two of those, we lost over 1,000 members.
And sometimes that's painful. It's a hard pill to swallow. But in the long run, these are the policies, procedures, and operational issues that do help making an ACO successful. And again, if you're not distributing checks, the model will fail.
It will fail.
So make sure that maybe it's painful, maybe we have fewer patients, maybe we make a little less money, or have a little less.
Some checks are better than no checks.
Some checks are better than no checks, exactly. And I think that, and including the stakeholders and all stakeholders, it's not just the partners, not just the providers. The benefit needs to sort of touch every stakeholder, and including them, making those arrangements formal, having introductions made to partners of the provider. Sometimes the providers don't know, oh, I didn't know that this was the nursing home we were supposed to prefer. Don't let those things happen. And that all comes down to one point, and that is communication and communication and communication. And don't have a predominance of your communication be via electronic means.
No, face-to-face.
Face-to-face is still very important. Remember, boots on the ground do all the work.
And those office managers drive the bus. So include them all the time.
Like any school bus owned by this school district, that's the provider's name, but the driver decides what route to take and what detours to make if there's a traffic jam. So please, please, please make sure that this is not all electronically. Apps, although we can talk to no end about apps and their benefits, some things still require a personal touch and a face-to-face. And do not, patients especially. Providers, next. Partners, you could get away with having infrequent contact. Again, the partners are watching how you're contributing to their bottom line, not necessarily anything else. And while they're delivering good patient care, if their bottom line doesn't get, if the needle on their bottom line dashboard doesn't change, that partnership is of no value. And so with some programs, with some clinically integrated networks, you can continue to narrow the network, and it's becoming more a reality than ever was. It was a theoretical exercise 2 years ago. Again, with the direct to provider contracting that even CMS is offering, that network gets very small very quickly, and patients have changed their behavior to buy HMO products, narrow network products, exclusive network products, because it costs them less on a deductible and copay. So behavior is changing, and stay ahead of that curve.
It's a fluid situation.
Yeah. Anything else, Cliff, we've missed?
I think we're kind of up against the time wall.
So I think we'll now open it up for some questions, and happy to answer any that might come up.
All right. Well, thanks, guys. We did have a few questions come in, so I'll go ahead and go through a few of them. I don't know if we'll be able to get to all of them. If you are listening and want to submit a question, on your panel, there's a question section where you can put in a question. So please do that now if you would like to do so. All right. So these are directed at neither one of you specifically, so I'll just kind of go through some of these. The first one is, can you give any examples of patient enrollment with payers?
Yeah, I think both of us have had different sets of experiences where with a couple of our ACOs that were running predominantly a Medicaid program, a shared savings program, or a shared risk program, auto-enrollment was a massive issue. Sometimes as many as 30% or as much as 30% of a provider's panel was auto-attributed, and they had no idea that this patient was assigned to them. That became a conversation with the payer to not simply physically mail a list of patients, but we had technology solve that, where we started alerting the practice that they got a patient auto assigned this month, and that changed how the practice approached auto assignments. Instead of having to deal with 400 patients from a list every day, a new patient appeared, that provider's practice got notified that, hey, you've got a new patient, maybe we should reach out to them. If you've had a different...
In our view, it really, the attribution list churn was such that it really affected how we decided to go forward with Medicare, where we chose the prospective enrollment model so that at least come January, we'll know who we've got for the whole year.
Right.
And that's really important, because if you under the current model, you don't really know who you had till 6 months after the close of the year, and that's so you're kind of chasing a lot of rabbits, and you don't know really if you got the right ones. and quality metrics and everything else. So this way, at least we'll know who we have. Now, when that patient moves to Florida from New Jersey, we got a problem because that patient is still in our pool. But at least, again, we know who we've got and what kind of outreach we may need to make.
Okay, great. Second question, have you found any differences among unmanageable patients if they are Medicare, Medicaid, or commercial?
Yes. The first thing is we track leakage for each of those, and there's a significant difference between commercial, higher, Medicare kind of in the middle, and Medicaid low. Because and that may be more due to the Medicaid members having fewer transportation access points, plus the list of Medicaid participants is less. Often these supergroups don't participate in Medicaid.
I think in the Medicaid population, the primary issue we typically see is the percentage of patients not coming in for care at all, because they tend to be younger, and they, generally don't think they're ill, don't think ahead of prevention. So education also plays an important role. But we know that education and income sort of go hand in hand, and automatically those issues get translated into access and transportation. So yeah, we've seen a different unmanageable category between the three patient cohorts that you're talking about: Medicare, Medicaid, and commercial.
Okay, great. Next question is, do you have any examples of provider motivation tactics?
Cliff, I'm sure Cliff can talk to no end about it, but I'll give you one really cute example that we've seen a lot of success with. Is that we had monthly meetings for providers where we were educating and training and talking about strategy. That attendance was becoming an issue, so we created a small incentive pool of dollars. I think it was $100 per provider, but they had to come armed with one of their own statistics that they had received in that month from the visits from the care coordinators or the administration of the ACO, either on admissions per thousand or ER visits or high-risk patients. One metric they had to come to the meeting with, and at registration they gave the metric. The registration desk had all these measures by provider, so they matched and said, yeah, you know your number. And they got a $100 gift card, Starbucks and local restaurants. Having a large meeting, some of those dollars were funded by the quote-unquote partner, So, we've seen that as a example, and Cliff has some really good examples of how compensation agreements were changed, or the tactic we used, Cliff, to move to a risk-based contract.
Yeah, that's the big one. I mean, the first thing that gets people's attention is a track record of delivering checks. Bonus after bonus after bonus. We also tried to use the care management fees as kind of a motivator, but the docs just pretty much put those fees in their pockets and didn't really change anything. So we eventually kind of insourced that care management work to the central office of the ACO, because that's where it really was happening. But I think the bigger thing that we've seen is by giving doctors a regular set of data and showing them where they rank, particularly on quality, with their colleagues, that has supercharged everybody, because frankly, one year we missed $400,000 of bonus because we missed 81 mammograms out of 3,200. So that was just stupid on our part. And so since then, the quality metrics, we've been in the 90th percentile on 5 or 6 every year. And that has been because Our doctors are very motivated by that, and their office staff. So just kind of getting, it's not so much necessarily just the doctors, but if you get kind of the office leadership involved in that, they'll work the doctors and they'll tee up the questions. One of the things we have not done, and I'm not sure this is right, but we have really not interfered with the doctor's existing workflows. Whatever they got, that's what we kind of work around or through or with, even if it's not, central to, or not performing the best. We think it's their job to figure that out, not our job to tell them, what to do. And since we only have 20 or 30% of their patients, they still have a life to lead outside the patient, and then ultimately these are their patients, not our patients, and we're respectful of that.
I think more the ACO assisted the practices with the ACO operations and took away the burden from the practice. We found that the providers were very grateful for that.
And what the providers have done, all our primaries, is to give us access to their individual EMRs as if we were employees. So we can look up through a secure data line, we can look up what we need on any given patient so that their staff doesn't have to do that. So like for GPro, we had 22,000 data points and probably 18,000 of them we were able to get without bugging anybody.
One of the things that has not worked, it was a really cute idea. It was in Texas and in Brownsville, Texas. We had an ACO and they put up a wanted poster, the typical, touched up image of the provider in a wanted poster with, the hat and everything that said, today's most wanted, and the dollar figure at the bottom was a reflection of their individual PMPM or variance on the benchmark. And they thought that the doctors would pay attention to it, and it backfired so badly. So we've also seen some really good ideas backfire, so be careful. Think through and get one of test them. Get one of your providers face to face and say, what do you think? And they'll tell you. So be careful. Yeah.
Okay, great. We got a couple more questions and then we'll wrap it up here. Next question is, what type of partnership agreements have you experienced with skilled nursing facilities?
We've done two. I think Cliff has a model and I've seen a different model. The model I had was we went to the skilled nursing facilities with the 3-day waiver upfront and narrowed the network of choice. The hospitals, discharge coordinators were very engaged in that, making sure that the patient's choices were not limited, but a preference was communicated. It was done in writing so that there was never a nebulous issue about, hey, are you not telling about, telling the patient and their family about a nursing home that was not in the network. Proximity and affiliation with the provider did make a difference. That those skilled nursing facilities that were in the provider network funded care navigators to be engaged with the practices and in the hospital, so that they they maintained continuity of care, transition of care, while making sure that they got the anticipated volume from having such a relationship. So that took off a fair amount of cost from the ACO's operations. That one had 3 care navigators, so think about $300,000-$400,000 in savings per year just from an expense side. However, it gave us better control about readmissions and length of stay. I think they started off at 28 days and they dropped it all the way down to 23. So there were multiple benefits that both sides saw. And that was a model that did work. I know you had a slightly different approach.
Well, it was pretty much the same at the front end, but we actually reduced the expectations to a letter of agreement. It was like a 2 or 3 page letter of agreement. Thou shalt and thou shalt not, and we shall and we shall not. Again, we went from 15 to 6. based on Medicare scores,
Star ratings.
and the doctor's preferences and their cost performance. And we included the hospital discharge planners scoring of whether these nursing homes were cherry picking or otherwise cooperative, they take anybody, or they put up a lot of resistance if not. So we're just rolling that out now, the list, and because we get started with the 3-day waiver come January 1. But really, what we were looking for is hospitals SNFs that don't have a low readmission rate and have a low kind of bounce rate to the ER.
What we have seen in both instances, one with formal agreements and one without, is bed availability became a non-issue.
Yes.
And so holding a patient in the hospital waiting for a SNF bed has been eliminated. So that's
we're hoping for safe.
Yeah.
Okay, great, guys. Well, we are out of time, and we do have a couple other questions, so we will plan to reach out to you individually. But at this time, wanted to wrap up and wanted to let you know that this webinar will be recorded and will be available for review at the ACO Exhibit Hall website, and which is also where you can visit the Health EC virtual exhibit booth, and you can get more information on them and connect with their team, and it's really cool. I would encourage you all to check it out. Lastly, would like to thank our speakers for today. And if you have any questions for them specifically, their contact information is on the page here, so you can make a note of that. And again, these slides will also be available at the ACO Exhibit Hall website for download, as well as reviewing the recording. So that is it for today. Thank you all for attending. I hope you found today's presentation informative and helpful, and hope that you will reach out soon. Have a great rest of your day, everybody.